The population of older adults will exceed 95 million in the United States by the year 2060. As Americans age, our emergency departments need to adapt their models of care to address the unique needs of older adults. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. Age-Friendly Health Systems, an initiative of the John A. Hartford Foundation and Institute for Healthcare Improvement, in partnership with the AHA and the Catholic Health Association of the United States, is a movement that aims to enhance care for all older adults by implementing the 4Ms framework that's focused on what matters to the patient, their medications, mentation, and mobility. Julie Dye, clinical nurse specialist in geriatrics at Sharp Grossmont Hospital, shares the benefits of participating in the age-friendly health systems and geriatric emergency department accreditation programs to identify gaps in care that improve the experience for patients 65 and older and their caregivers. Sharp Grossmont's supportive leadership team provided the emergency department with the staff and resources to treat the whole person by blending caseworker skills and clinical expertise. In this conversation with Marie Clary Fishman, Vice President of Clinical Quality at AHA, Julie discusses staff buy-in, asking what matters to patients, and leveraging trusted community partnerships to better serve the population of older adults in the San Diego area.
Well, Julie, thank you for joining us today. This is really exciting. As so many people know, Age Friendly is near and dear to my heart. And I'm hopeful that by the time I need to show up in someone's emergency department, that all the emergency departments are geriatric emergency departments and our hospitals are age friendly. So that's a great goal for everyone. So maybe could you start a little bit by giving us an overview of how your journey started with Age Friendly and where you sort of picked the geriatric emergency department to start with, and just give a little overview and then we can dive into some of the more specific areas for our audience.
Absolutely. I'm really lucky. Our administration is very forward thinking, and they oddly brought it to us in 2019 at the end of the year. They said there's this geriatric accreditation for the emergency departments we should look at. And so we started looking at parts and pieces and thought, well, we're already doing all these things. I don't know that we need it. But then once we did a deeper dive and getting our clinical informatics team on board right away, we were like, oh, this is definitely not happening the way I think people thought it was happening or the way it was envisioned. We started realizing there were large gaps in care, and that was right before COVID. So we had actually started toward our geriatric accreditation, and then of course COVID hit. So again, I think where I just am so appreciative to our leadership, most places understandably stop projects because of COVID. Everybody was really short on resources. We really had a difficult time during COVID, but our administration said, no, we need to keep pushing forward and actually go for gold because this is the heaviest hit population. The caregivers are all often also older adults and really need a ton of support. So where we had recognized gaps before that might have been cracks during COVID, it suddenly was just, these Grand Canyon size gaps in care and issues. So we started to go for our gold in 2020. It was funny that the team started off pretty small where we were like, okay, well, we need a pharmacist and maybe a social worker. And then it became, well, we need these guys in therapies and we need these nurse navigators. And it's now grown to this just enormous team of people to make this go. So it's really been a fantastic journey. And then we had discovered the Age Friendly initiative through the American College of Emergency Physicians and thought, gosh, that adds another layer. We're already doing the medications, the mentation and mobility, but we were interested in the what matters piece. It's such an important thing that doesn't tend to get addressed in the emergency department. We're pretty pragmatic that way. You come in, you're here for your broken toe or you're here for your heart attack, and we're here to fix those things, and really trying to marry that social and psychological and that whole person with that medical complaint, make sure that we're doing all those things. And so we really discovered some interesting things through going through the age-friendly journey and adding that extra layer that ended up being really important, and again, allowed us many actionable items and allowed us to involve other teams. And so it's really been a wonderful marriage of all these different interdisciplinary teams. And it's been fun to see how it's grown out now into the community as well.
Well, you have just touched on so many key important things. I feel like we could be here for a long time going through them all.
Legitimately.
Yeah, and one of them I just want to pause and say, because I know as time goes on, maybe we don't hear this as often, but thank you so much to your team and everyone at Sharp Grossman who worked so diligently for all of our patients during COVID, and especially for those geriatric patients, because it was particularly difficult for them. And I love the fact that you hit on the what matters, because so many people were separated from their caregivers or separated from their families, and it made it really difficult. Could we pause on the what matters for just a few minutes? And maybe for our audience, you could just describe what matters a little bit more depth for the audience. And then I just want to talk a little bit more about it. But if you could start with a description, that would be great.
Absolutely. So we ended up choosing what matters in life and what matters this visit. We always have to marry it a little bit with what are we going to do with the information and how can we make it comfortable for the patient. That was a big lesson we learned is
Sure.
they're a little off put sometimes by the questioning. And so we had to learn how to script it such that we're earning trust, that we're, explaining what are we going to do with this information, once we get those things asked. So we chose those two questions to give us a really good idea of, where are you at in life? When was a good day for you? What does that look like? What are your goals? Those really big questions. And then what really matters to you this visit? And how can we marry those two questions? And so oddly, that ended up being a big part of our program because it forced us to start at the beginning of the visit with, are we even having the right conversations as far as what care looks like? And in some cases, we discovered, we've had patients who've said, I just want to be done.
Sure.
I'm not eating because I don't want to go to the doctor anymore. I'm tired of suffering with these symptoms and things. We were able to loop in teams more toward that end versus, oh, let's go to cath lab or let's go to surgery or let's go here, being able to do a better assessment of what their goals are and marry those things. And in some cases, that looks more like, depression from needing social support. I'm losing my house. I can't pay my bills, things like that. So then we're able to say, okay, well, yeah, let's fix your medical issue today, but let's also get these other things in to make life easier, help you be independent longer. So asking those questions has been a huge part of the program that we really weren't anticipating would be as important as it is. It's also given us actionable information where we've been able to create community partnerships. So, for instance, what matters in life is often people's animals. And for these people, sometimes those animals are legitimately children for them. So we were finding that patients would AMA from the emergency department and from the hospital because they were worried no one would be there to take care of their pets. And so we were able to partner with the Humane Society and say, if you can provide us emergency animal services, we can encourage these people to stay and get appropriate treatment. So it really did have actionable outcomes for us and really helped us understand the right teams and the right resources to involve early on in the visit, help get the provider on board. This is what the patient really wants. These are the conversations we need to be having versus jumping immediately to how do we fix the medical problem, if that makes sense.
Oh, it makes so much sense. And I think the fact that you worked with out in the community to find a partner that would help. I mean, as an animal lover and someone who's getting older, and I think, oh boy, I better make plans for those animals. But making that connection for people is so important. There's a whole nother case study there, Julie, for us to look at, I think.
Well, and honestly, I'm so lucky. We have the Senior Community Resource Center run by Dan and Natalie and Lorraine, and they are an amazing community resource because it isn't just a list of, oh, here's a list of numbers where you can get meals. These are all vetted resources. They have personal relationships with people. They can really tell you, oh, you should use right at home. You should use, these following services because we have good relationships with them and we know you're likely to have a good outcome versus, oh, we went to Google and we found that these following people, are helpful with home health and, or helpful with yard work or things like that. We can really tell them, hey, we feel really good about these resources. We can help you. We can call you back and see how you're doing. We're incredibly lucky to have that community resource center here at Sharp.
That's great. That's so amazing. Now, let me ask you a little bit more about that, but I want to take it in another direction, and that is toward the workforce. So, as you're talking, and my nursing background, and I think about being back at the bedside or back in my role in quality, and tell me a little bit about how the what matters helps with the workforce, or if it does. We hear reports, and you made the comment about this started before COVID and it kept going. It was one of the things we've heard that over and over from folks. This is one of the initiatives that people felt they could keep going with during COVID. Tell me a little bit about what this does for the workforce.
It's interesting that you should say that. I wasn't sure how they would receive it. Most of my nursing career, we've been in a nursing role and social work is in a social work role. So we're pretty siloed. And so what I'm loving about this and really what the nursing staff has reported back, especially the nurses that work in this capacities, they really have enjoyed learning about the case management and social work role. What they're starting to realize is if the person can't comply for social reasons, whether those are psychiatric, cognitive, financial, you know, there's so many reasons that people struggle, then they simply can't be compliant with their medical care. And so you'll just continue to see them, come back to the emergency department, often in worse shape. And that's been a frustrating thing for nursing is the patient will come in, we'll do all these great medical things, we send them off into the community, they come right back. And it's a simple question. Did you fill your antibiotics? Did you fill your heart failure medication? Well, no. Gosh, I noticed you were here earlier this week for having high blood sugar. Did you know how to use your pens? Well, no. So realizing while we physically have them here and we can see them, they have difficulty seeing, hearing, things like that, realizing we need to bring the care to them. So if we have them in a gurney here in the emergency department, this is the time to assess for all that whole spectrum of things to make sure they can be successful at discharge. Do they have all the things that they need? Do they have the education they need? Do they have a scale? Do they have a blood pressure cuff? Do they have the things that they would need to be successful? So I think it took a minute for the nursing staff to start realizing, am I doing a full assessment of this person and then adding that piece in? Are we even having the right conversations? Okay, you may have all of those adjuncts, but are you tired of living with heart failure or your symptoms are poorly controlled? What really matters to you? Does it matter that you get to go on that trip to Maui? Is that more important than spending a night in the hospital on observation just to make sure everything stays stable for the next 24, 48 hours? Those kinds of things are really important conversations, especially when it comes down to holidays or things like that. We started discovering, especially during COVID, where people were the hospitals were on lockdown. These people were spending what was quite possibly their last holidays here alone. Maybe that wasn't their goal. Many of these patients would rather be at home, even if that meant an impact to their physical outcome that was more important to them. So asking that question helped us really understand what their goals would be and make sure that we're aligning with that.
I love that detail, and that at the point is so important. What do you want to spend your last time doing? And is it sitting in a hospital? Is it sitting right? Where is it? What do you want to do? I mean, if we all thought about that on a personal level and then applied it. My dad's 92. He lives with us, and I certainly know it's not in a hospital, even though he loves the fact that I'm a nurse, but it's not where he wants to spend his time. So that's a really important thing, and that's important for the workforce. And I love the fact that that message has gotten through. You have a GEM nurse.
Correct.
Can you talk a little bit about that role for people so that we have an understanding of what that is and what are some of the things that position does?
That role is a game changer, honestly. So it's geriatric emergency medicine, and we actually recruited from our staff. So what we wanted was people who were passionate about marrying again that case management social work side with the nursing side and really being essentially a hub or a nurse navigator. So we recruited from the staff. We had a whole list of interview questions and things. We really wanted to get to the bottom of what did they hope to accomplish with the role? What did they want to learn from the role? Most of the people who applied had been a caregiver in some form or fashion. and realized how impossibly hard it is to be a caregiver and the amount of caregiver strain.
Right.
And that's often what brings people to the emergency department is they are unpaid, untrained. San Diego is one of the most expensive cities in the union. Everyone is struggling so much, but you don't know what you don't know. And so you just keep struggling at home until you're finally like, I can't do it another second. And then you come to ED and you're suddenly tapped out. So we really wanted to grab nurses who understood what that's like for caregivers. Some people have chronic illnesses themselves and know how much of a strain that is to manage things like diabetes or, where it's just a constant daily battle to stay healthy yourself. So it was really a great thing to have these guys on board who were excited about the work, really wanted to learn how to marry those two things. And again, I can't say enough great things about our leadership. So they gave us a full-time equivalent for this role, 7 days a week. It's really, remarkable.
That's amazing.
And it's a game changer, honestly. Initially, the providers weren't sure what to make of it, like, "Who's this person talking to me about these things?" And the nursing staff will get frustrated if there's not a gem there where they can use them as a resource. So that's been a lovely thing to have, evolved out of this. But they have their own workstation. We do a lot of work through Microsoft Teams, which is nice because we can have living documents there that people can update. So we actually have a live link with our community resource center again. Essentially, when somebody checks into the emergency department, every nurse here does a quick functional assessment called the ISAR or Identification of Seniors at Risk assessment. This helps us understand because 65 is pretty young. A lot of 65-year-olds are very functional, healthy, working, golfing. We want to make sure that we're targeting resources to people that are really starting to struggle. And sometimes that's just not obvious. So we do that. These guys look for people who've been here within 30 days, chief complaints that are concerning, things like that. So they go out and perform a comprehensive geriatric assessment that has many parts and pieces that you're aware of. And they take the information from those things and then start calling these interdisciplinary teams. So that might be our ED case manager, that might be therapies where it's like, gosh, this was just a simple trip and fall. They look really good. Their x-rays are negative. Could we send them home with durable medical equipment versus admitting them for OBS? In some cases, that's like, gosh, we've noticed you've been here for DKA, twice this month. Let's have the diabetes educator come see you, or let's have dietary come see you and see if we can close some of those gaps. Maybe you need home health. We've done some partnerships that way that have been really exciting. So these guys are very much in a hub nurse navigator position of, gosh, this person's been here for heart failure several times. Maybe the heart failure clinic would be the right bridge to cardiology for these guys. And so they'll take that whole assessment, go back to the provider. These are the things we've found. I feel really comfortable with them going home with resources, or gosh, this person's just not safe at home. We really do need to admit and figure out what's next. So that navigator position is irreplaceable.
That's great.
And the last thing they do is they call the patients back after discharge and check on them, which has been a lovely adjunct. It's the patients love getting called, and it allows us to identify gaps out in the community before it becomes a crisis where they have to come right back in.
Somebody's there to check in on them. That's awesome.
Oh,
That's
they
really
love
great.
it.
Oh, I love hearing about that position. So I know we get close on time, and I really want us to be able to talk for a longer time. One thing I want to talk about is dissemination and spread through an organization. So let's circle down to that area, and I'd like to hear a little bit about your experience and what you think is key to have in position when an organization wants to look at spreading this, spreading age-friendly, doing their geriatric ED. Give me a little bit of your sense and experience, and what do you think leads to success in an organization that wants to spread?
I think honestly, it really is resource heavy, but it does come back and help you via improved care, patient sat, things like that. We have so much throughput pressure in the emergency department, so many issues with boarding, and certainly that affects geriatrics the heaviest. Boarding is just so bad for them. So it is really nice to have separate resources where this is their only job. They can go in, do a quick assessment, hand off to somebody else to be able to fill those gaps. We did try initially with the geriatric emergency nurse to do everything themselves. So they would do the full med rec, call, use SureScripts, call the pharmacy, call the family, do all these different things, try to call the physician. And they were seeing, 2 patients the whole shift. They're just very complicated patients. So investing those resources is scary for organizations, understandably, and everybody is hurting, but it really does help provide that total picture. You have the experts working on each of their parts and pieces, so you feel really good about that discharge. If it's something where we're on the fence, we know physical therapy has done the exact same evaluation they would do in patients. So we feel really good about, hey, this person could have a modified walker go home, or we can hook them up with home health. We have some great partnerships and we know they'll get seen right away. And so some of those things helps everybody feel better about the plan of care, including the patients. We're respecting what they want. If they're saying, gosh, this is how I always look when I walk, I have Parkinson's, I'm not going to look like I walked when I was 20, but I feel comfortable going home, we feel comfortable supporting their goals. So that part I think is really important, is having that administrative support and that willingness to put that resource behind this program, but it really does pay off in spades later on, if that makes sense.
It does make sense. It really does. And I'm going to circle back, and I think we'll, kind of bring things to a close on this topic, because you've said it several times, and that is the support and the involvement of your leadership. And it just sounds like that's an amazing kind of thing. And can you define leadership for you? When you say your leadership, can you tell me a little bit about what that means to you? Does it go all the way up the C-suite? Does it involve the board? Can you give us a little bit of a sense of what leadership means? Because I think it's so different for everybody. And I also think that the model of how leadership gets involved can be so different. So give me a little bit of info about that.
Completely agree. So we're really lucky. Our CNO and really our CEO are really the ones who wanted to spearhead this in the first place, based on their knowledge and their past experiences, and knowing that this large volume of people was expected to come. They have a lot of forethought to realize this is the growing population and this is where the need is at. So it was really easy to support their vision as well. To your point, though, we have an interesting situation at Grossmont. We're a public-private partnership. So we are partnered with this foundation that is amazing as well. They really want to help support us. We do report outs to them. They support us with funds in some cases. They're very supportive of our work too, and they're very invested in what do we bring to the community. So they want to see us out there providing free classes. Our community resource center here at Sharp Grossmont provides free classes for caregivers on how to do caregiver mechanics, how to support them psychologically, because being a caregiver is just so psychologically heavy. All those types of things have been supported by our leadership. They've given us that FTE, they've given us money, they've helped us improve the environment of care, they've allowed us to repaint, add dimmer switches, add different equipment. They've allowed us to hold classes. We hold community clinics and get togethers for free. Those things are all supported by our foundation, the board, our C-suite level. I mean, we are on a first name basis with these people. They've always had an open door policy with us if we're concerned about something. And I think that part is irreplaceable as well. They're very close to us, in other words, versus, being somebody who sits in an office across town, and I wouldn't be able to pick them out of a lineup. We really have a close partnership, which I think is irreplaceable. And that helps support our local ED leadership as well. Our directors have been amazing. They are very responsive to anything that we need. Our ED manager is amazing. So we really have a ton of support for the program. And I just honestly don't think we could do it without that, especially knowing how strongly, how much pressure they have to address throughput and make sure all of their other metrics are being met. The fact that they're still have so much support for us is just amazing and irreplaceable, frankly.
Well, that's a great message, Julie. And I think that's a great place for us to end our conversation today. Even though I'd love to keep going, we'll go have more conversations at another time. But congratulations to your leadership as well as to your frontline team and everyone in between on achieving the successes in age-friendly healthcare and that you have at Sharp Grossmont, and for working with us and for being willing to share this message and this story across the nation. We're very grateful for you, and thank you so much.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.